So for all of you who have joined us, I think I'll go ahead and just pop up our little poll. We're going to do a real quick poll of everybody before we get started, and that maybe you guys can entertain yourselves while you're there, waiting for us to get started. So just to see, test your knowledge just a little bit, I'm going to launch a little poll asking, what is the recommended age to begin colorectal cancer screening for most people? And if you'd like to and think you know the answer to that, just give a quick, good, I see some of you guys are doing that. And we'll see how smart everybody is who's on, well, not smart, how knowledgeable everybody is about colorectal cancer screening guidelines once we get started. If you don't know, you will know by the end of the presentation for sure. For all of those of you joining us, we have a poll open. If you want to just quickly answer the poll, what do you think is the recommended age to begin colorectal cancer screening for most people? And some of you haven't answered yet. If you don't know, that's okay. It's anonymous also. So you can just make your best guess. Okay, it's 12 o'clock. Let's go ahead and get started. I'm going to leave the poll up just for a little while I say hello. Welcome to everybody. My name is Carlin Raffi. I am an extension specialist with Virginia Tech and Virginia Cooperative Extension, and we are so happy to be putting this event on. If you haven't answered the questions, I'll give you 5 more seconds to answer that quick poll. What is the recommended age to begin colorectal cancer screening for most people? As a quick kind of background information about what's going to happen during this presentation and afterwards, we are recording this presentation, so it will be available to you and to others after we've completed it, and we will mail out to you a link to that recording as well as a copy of the slides that will be used in this presentation. There will be a quick survey at the end. If you complete that survey, you will receive a certificate of attendance if that's something that is valuable to you. And we encourage you to complete that short evaluation just so that we can know how you liked this presentation and other webinars that we could plan for you. Okay, I'm going to go ahead and end this polling. And then we'll quickly share those results just to see what everybody thought. So can you see that, Kristi?
I can.
Okay, good. So we have, and I'm going to let Kristen give the correct answer to this, but what is the recommended age for colorectal cancer for most people? About 45% of you thought it was older than 45 years of age, and 55% thought it was 50 years of age. Kristen, you want to tell them what the answer is?
They're both correct.
Oh, there you go.
They are. The recommended age to start with preventative colon cancer screening is actually age 50, based on the American Cancer Society. But the recommendations have been changed for the African American population to 45.
So that was a trick question.
I know, but and I can see them reducing to 45 in the near future.
Great.
Right now it's 50 for most.
Great. And after this presentation, you'll know why. So also real quick, because we have a relatively large audience, you guys are on mute, and we'd ask if you have questions while you're listening to the presentation to please go ahead and write those questions in the chat box. And so this slide shows you where you should find that chat box. It's probably at the bottom of your screen. There's a toolbar, and this toolbar has a chat feature there. If you hit chat, the chat box will come up, and that's what it'll look like. That's the chat box if you haven't used Zoom before, and you can type in your question down here at the bottom, and all of the panelists, as well as you have the option to allow everybody who's in attendance to also see your questions. So that's how we'd like you to ask questions or make comments, and we'd love you to do that. We'd love to answer the questions for you. So without further ado, I want to introduce Kristi Seay. Kristen is a nurse manager at the VCU Alvin M. Zfas endoscopy unit. Kristen has both a BS and a master's in nursing, which she received from Walden University, and she has a focus on leadership and management. Kristen has over 30 years of experience in endoscopy, so she's a very experienced nurse in this area. She is on the board of the Old Dominion Society of Gerontology Nurses and Associates, the director of the board of the American Board of Certification for Gastroenterology Nurses, and she's on their item review committee as well. She's also the chair of the board of Hitting Cancer Below the Belt, which is a nonprofit organization that's promoting colorectal cancer screening and prevention. And so she has a wealth of experience that she's going to bring to her presentation today. And without further ado, I'll just let her get started.
Hello, everyone. Welcome, and thank you so much for allowing me to join you today with the COVID scare out there. I really appreciate you taking your time to listen to this information. I became passionate and actually looked into doing this presentation just because I saw a rise in our endoscopy units in the past with our younger population, and it was quite devastating to me. When you go in with a physician and you have to tell a young person that they have colon cancer and you know it's going to be like a life-changing amount of information, it just was very devastating to me. And it's like, how in the world has this happened? As most of you know, we do colonoscopies as a prevention. I have been in the endoscopy field for 30 years. I left the emergency department at where I was at the beginning of my career and made my way to endoscopy, and I was concerned a little bit about losing skills or being bored, and I have not been ever since. It's a field that we are just vastly growing. So next, I'm going to review the objectives for my presentation today. So we're going to be discussing the current colorectal cancer, or you will see somewhere in my presentation and on the slide CRC, and that stands for colorectal cancer, rates for various age groups, including the millennials. That's who I'm focusing on today. We're going to discuss the CRC causes, risk factors, including available testing. We're going to review a variety of case presentations. I have those just kind of scattered throughout my presentation just to kind of break it up a little bit. We're going to discuss the challenges involved with a CRC diagnosis in the younger population, because you get a few extra challenges with this age group, and discuss the future of colorectal cancer rates and how we can lower those. Okay, oops, I'm waiting for you to change my slides. There we go. Okay, so first of all, I want to tell you, and this is a real life story. I don't have her picture, but Rachel Wintergar, she is a mother of 3 from Colorado, and this was a case study that I found within my research. She had years of digestive system issues, and the problems intensified when she became 30. Colorectal cancer never crossed her mind. She had no family history. Her doctor thought it was a condition like either celiac, ulcerative colitis, which sometimes you'll hear that called UC, or Crohn's disease. Her symptoms included rectal bleeding, even when she was just passing gas. She had the sensation of feeling full. She was bloated, nauseous, low energy, feeling as though she were sitting on something, and pencil-thin stools. The change of the shape of your stools is a very big indicator. Unfortunately, she was diagnosed with a colonoscopy, and it revealed stage 4 rectal cancer. Only 30 years old. Okay, so who are these millennials? You know, who falls in this category? So the millennials is an extremely large group of people. They are also called the Gen Y. So the ages for that generation are between 25 and 39, or they're born between 1980 and 1994. So you can look at those ages and you probably have someone or know someone that falls in that age group. So I think we were going to do a question on that, weren't we? Okay, so the millennial age group is so large, it's actually broken into a Y.1 and a Y.2, which I found fascinating. I didn't realize that. So the younger aspect of this age group is 25 to 29, and that's 31 million people in the United States. And then the Y.2 is even a larger group at 29 to 39, and that age group, well, it's a caveat of 10 years, 42 million people. So this is definitely our generation that we need to look out for. It's very large. So other generations, so that you could see from that generation up are Generation X, and those are folks that are 40 to 54 years of age, and they are about 82 million people in the US. Their ages fall between 1965 and 1979. And then we have the boomers, that big generation, 55 to 75 years of age. They are 76 million people in the US, 1944 to 1964. So that is a large generation, and that's where most of us are looking at these millennials, because they're going to be taking care of us one day. And then we have the silent generation, and those are is the population that's between 70 and 89 years of age. So colorectal cancer, I started this presentation and doing the research for it back in 2017 and 2018. It is still the second leading cause of cancer death. About 140,000 people will be diagnosed with colorectal cancer. And out of that group, about 49,000 of those will actually die from colorectal cancer. The median age for colon cancer has been about 66. And the initial increase of younger patients getting diagnosed, all that started in 2009. We started seeing that trend. So colorectal cancer is the only group of cancer where the incidence is on the rise, especially those under the age of 50. We've kind of got our handle on some of the other systems that experience cancer, and we're noticing that for colorectal cancer, about 11% falls in colon cancer and 18 fall in rectal cancer, and those are of our patients that are under the age of 50. So we have the age groups are between 20 and 24 years old to 45 and 49. We're seeing the incidence of 0.85 to 28.8 per 100,000 individuals. We're seeing the increases occur in 5-year age groups, and the sharpest increase of diagnosis that we're seeing now is age 40 to 44. So people born around 1950, that was our group that that have gone through the era where we're doing the screening colonoscopies at age 50. And the American Cancer Society is now reporting that that age group from 1890 to 1950, we're actually seeing a drop of colorectal cancer in this age group, which is huge. That's wonderful. That means that our screening colonoscopies that we put in place, that insurance companies are now approving, which they were not doing in the latter 80s, early 90s. But widespread screening tests like colonoscopies have greatly impacted this decline. I started in endoscopy in 1990, and at that point in time, a lot of people didn't even know what endoscopy was, and it was kind of still that little, hush hush, let's not talk about it, it's embarrassing. But it has really grown in popularity, and thankfully we've gotten these good results as a result. So can you click on that, Carlin? I hope the sound came through for that. I wasn't sure if it did. I couldn't hear from this end, but I want to tell you about this message. This is a friend of mine, Roger Chasm, and I work with him with hidden cancer below the belt. His wife, Mindy, hopefully she's on this call, is the founder of the organization Hidden Cancer Below the Belt. You can see the message down there in the left-hand corner. And so we work really hard in the community talking about the Fight Right campaign. So we talk a lot about what I'm going to be discussing today, which is nutrition, stress reduction. We have done a lot of campaigns and working with local communities and helping with fit testing. And so we've really been out in the community and doing a lot of work. We provide baskets for our patients that have been diagnosed with colon cancer, healing belly baskets, we call them. And we offer nutrition and classes every single month. So I encourage you after this presentation to feel free to go to our website, Hitting Cancer Below the Belt or HCB2. So we're doing a lot of things, and please join us. We have a 5K run coming up in June. Hopefully we can still have that. So people born in 1990, I am sorry to share these shocking statistics, but they're twice the risk of colon cancer, and they're 4 times the risk of rectal cancer. So why in the world is this happening? These are just shocking statistics. So about 1,195 colorectal cancer patients and survivors are under 50 now. 71% of those were diagnosed at stage 3 or 4. There's a real disparity for being diagnosed in a timely manner. And we're going to be talking about this in my presentation. There are a lot of barriers to getting diagnosis in this age group. So here's another case study for you. So this young lady, Christina Crespi, 27 years old, and her history involved, she was feeling symptoms of extreme fatigue, weakness, changes in bowel habits. For 2 years, she went through bowel habit changes. She was told many times that her symptoms, that was normal, they're in your head. And finally, she found the right doctor, and she was diagnosed with the stage 2 colon cancer. So fortunately, she, bugged her doctor that something really didn't feel right, and she was at a stage 2. Because the previous slide talked about how 3 and 4 are the big cancer diagnosis, is where we tend to see that. So the new trends are 30% of colorectal cancer diagnoses are now being seen in people younger than 55. The rates are among young and middle-aged adults, and these rates have returned to the rates that we saw 1890. And 1890 was before we were doing all the screening colonoscopy procedures. American Cancer Society has estimated 13,500 new cases of colorectal cancer will be diagnosed in Americans under 50 in 2017. And I'm going to have some more information because I want you to see where we were a couple of years back, and I'm going to be updating this information as we move forward. So I thought it would be interesting for us to see what's going on around the world. So in Canada, colorectal cancer diagnosis among women under 50 has increased annually by 4.5% during the 5-year time period of 2010 to 2015. Canadian men under 50 experienced an average per year increase of nearly 3.5% from 2006 to 2015. So it looks like our women have been diagnosed a little bit more. Of the country's population of around 37 million, nearly 12,000 women and nearly 15,000 men of all ages were diagnosed with colorectal cancer in 2017. And those were the most recent statistics that they reported. So here we go in America. In 2004, 10% of diagnoses were in people under the age of 50, compared to 12% in 2015. At the University of Texas, Anderson Cancer Center, 1 in 3 new colorectal cancer diagnoses involves patients between 18 to 50 years old, according to a surgical oncologist there. And the figures are even higher for rectal cancer than they are for colon cancer. So let's go a little further. Denmark, New Zealand, and the UK. There have been significant increases in colorectal cancer among people under 50 for the last 10 years. The 20 European countries found that over the past decade, the incidence of colorectal cancer had increased by nearly 8% per year among people in their 20s, 5% for people in their 30s, and 1.6% for those in their 40s. Most important thing is to pay attention to the symptoms. And symptoms can include a change in bowel habits that lasts for more than a few weeks. That other young lady had waited 2 years or didn't get any attention after 2 years. A feeling of having to have a bowel movement that doesn't go away even after you've gone to the bathroom. Rectal bleeding, dark stools or blood in the stool. Stomach discomfort, including bloating or steady abdominal pain. Unexplained weakness or fatigue, and unexplained weight loss. So the challenges with our younger patients is they're more likely to be uninsured. Not all of them in these age groups have a job that carries insurance. And we all can realize that patients with insurance are more likely to have preventative services covered. They're also more likely to go seek help when they're not feeling well. It's still challenging to have the colonoscopy done or scheduled in a timely manner. Some insurance companies classify the procedure the same as CMS, and this is something that I was at Capitol Hill a few weeks ago trying to fight and share with senators. But they consider preventative if no polyps are found. So the reason why we do colonoscopies is for prevention, right? So that's the reason for doing it. But we want to find polyps. Every single polyp does not turn into a cancer, but every cancer was once a polyp. So we want to remove those while they're small. So you go in for prevention, a colonoscopy, to make sure you don't have polyps, and then they find polyps. The doctor finds them, our team removes them. Well, then they change your diagnosis to a diagnostic because they've now found polyps and removed those. And some insurance companies and CMS are then not paying for the procedure because it was performed. Endoscopy is a little bit different because it's not just diagnostic. It can be therapeutic. So if you need something to be done, we can do it while we're in there, which is great. You don't have to take a bowel prep twice. But with the diagnostic, you have different deductibles and premiums that occur as well. So that's pretty devastating. It'll cost America billions of dollars to change this, I understand. So there are more challenges with this age group. 41% of a CCA survey, and that's the Colorectal Cancer Alliance, in 2019, respondents reported that they would wait 6 months after experiencing symptoms before talking to a physician. So it's still an uncomfortable diagnosis to make and uncomfortable symptoms to discuss. 67% of the respondents saw at least 2 doctors before getting a correct diagnosis. I just found that devastating. Some of the comments that came up on the survey, my doctors weren't looking for colon cancer, and my symptoms were pretty obvious in hindsight, but I don't think they're used to seeing this diagnosis in young people. So even the medical professionals aren't, that's just not their first clue. Younger patients are 60% more likely to have a diagnosis of a distal lesion than an older patient. So a distal lesion, what we're talking about when we say that is, we kind of start backwards. We start at the bottom with the rectum and we go up the sigmoid, descending, transverse, and ascending. So distal is ascending, which is on your right side if you were to feel your abdomen. The very bottom corner where your appendix is located. Most people know where that is. That's where the small intestine or the small bowel attaches. So most of the patients, that is where we might see them to have, actually I said that backwards. That is what, when we go in, we say that's the distal. But they're most likely to have a diagnosis of that. The results is the cancer may be less treatable because the symptoms are a little bit more subtle. So the biggest problem with this age group is that there's an increased risk when we actually make the diagnosis because we've allowed all this time for that cancer to grow. And so it's later in the course of the disease. And that's why my statistics earlier with our diagnosis occurs more in the 3rd and 4th stage of cancer. This is why that occurs. So what are some other considerations we need to think about with these younger patients? Much different than those of us that are in the 50s. So when a younger patient receives a diagnosis, you need to consider the emotional aspects and logistical challenges that occur in their medical treatment. So you really do need to have a multidisciplinary approach. You need to include social workers because there are going to be some increased demands because they're still working and trying to raise a family, nutritionists, sometimes psychiatrists because they need emotional support. All of it's very difficult to deal with, and fertility specialists because some of the women that fall subject to this diagnosis, they wanted to have children, and so they need to be consulted. So I have another case study, and this is Kara Stalton, 32 years old, and she had symptoms of constipation. She was treated for diverticulitis with antibiotics, so she had some abdominal pain, but then the constipation returned. When she was diagnosed, she had a stage 3 colon cancer. She had a colectomy just a few months before her wedding. So that could have been a devastating first aspect of her marriage if she had not followed through. And she was very relieved that she did not ignore her symptoms. So she just was one of those that was very persistent. And we appreciate that and encourage it. So increased risk for colorectal cancer, approximately 5% are hereditary, including conditions such as Lynch syndrome, which is caused by mutations in genes responsible for repairing errors in DNA replication. 20% of the cases are linked to a positive family history of colorectal cancer. So, and we see this a lot. And we say that if you have a family member that's had cancer, you definitely need to be on that younger screening. 3 to 10% of patients have a first-degree relative with colorectal cancer. So if we diagnose a mom or a dad, typically I just go ahead and start talking to them and say, make sure your kids get checked. There is a higher incidence and mortality for African American population. And that's why earlier 45 was a correct answer, because that is the criteria has changed for them. We're uncertain whether the family history is all genetic or whether it's environmental, so that is still up in the air at the moment. So what kind of tests are out there? So the original test that was done many years back, and this has kind of gone by the wayside, but it's screening with guac-based fetal occult blood test. We usually say FOBT. So the FIT testing, which is next, that is the more popular choice that doctors will do. It's fecal immunochemical test, which identifies intact human hemoglobin in stool and has improved sensitivity compared to the GFOBT above for detecting colorectal cancer. And the FIT testing is what we've done with hitting cancer below the belt, that we've worked a lot with different centers around Richmond in particular and the outlying areas to provide those tests for that population that needs that kind of assistance. Cologuard is another test that you might hear about, and that test will detect if there's any genetics within the results that predispose you to colon cancer. And if you have a colon polyp, it can make it turn positive. The one thing you want to remember is Cologuard is a diagnostic tool. And so that's very good. It helps people not have to go through the colonoscopy procedure and all of that, but it is diagnostic. You do have some false positives and false negatives. I didn't include those statistics. Of course, I'm an endoscopy nurse, so colonoscopy is important to me because we can do the diagnostic and the therapeutic with removing polyps at the same time. So another example, another case study that I found was a young lady named Kristen, 27 years old. She complained repeatedly about having blood in her stool while in college. She was diagnosed with internal hemorrhoids, and that is a very popular diagnosis of this age group in the 30s. But she had a mother, and watch out for mothers, especially if your mom's a nurse. Her mom kept pushing for more testing. So she eventually found a doctor that would listen to her mom, and she got a flex sig done. Now, flex sig is the sigmoid is right above the rectum, and then sigmoid. And so majority of the polyps are found in that area, which is the distal area. I explained earlier about how your colon goes all the way around. More are found so that we do just the short exam. That procedure we do not do very often anymore because polyps can be found throughout the whole intestine, so the whole colon, so we like to look at the whole thing. Anyway, her doctor detected a very large tumor, and he was just shocked, 27 years of age, and we still are to this day. She had advanced colon cancer 1 month after college graduation at 22. And she was treated with surgery and chemo, and when I pulled this data, she was cancer-free. So here's some other historical data regarding colon cancer rates. So in 2017, when I pulled this data, I pulled it in 18, but anyway, 20 to 39 years of age had seen increases from 1 to 2.4% since the mid-80s. The 40 to 54 age group had already increased from 0.5 to 1.3 since the mid-90s. And then there's our 55 years and above rates that were dropping. So then next I have the rectal cancer rates. So the 20s, we saw increases in 3.2% during the years of 1974 to 2013. So this has been going on for quite some time. 55 or younger, 15% were diagnosed in 1989 to 1990, but 30% were diagnosed in 2012 and 2013. So we're really starting to see that increase there. So next I found a case study about a young man, Chris Roberts, 29 years old. He had a loss of appetite, lost weight, 20 pounds without trying, and he always enjoyed eating. He was fortunate to find a physician who was determined to make a quick diagnosis and find out why he was losing weight. And I think many of us know that losing weight is something you really want to pay attention to unless you're trying. The physician ordered several lab tests, including an ultrasound. He had an ultrasound, and tumors were noted in the colon, which had already spread to his liver. So that's pretty devastating. That means he had either a stage 3 or stage 4 colon cancer, because he already had metastasis to the liver. That is where we see colon cancer typically go next. He was treated with chemo and surgery. So our future rates that we're seeing now, by 2030, the age group of 20 to 34, we're going to see it's increased by 90%, what we currently are seeing. Ages 35 to 49 increases by 28%, and increasing for both Gen X and the Millennials. So why is this happening? It's about time you got to that, Kristi, right? So there's a young lady, Rebecca Siegel, at the American Cancer Society, and she provided a hypothesis that the obesity epidemic is directly related to the increase of colorectal cancer rates, but it could not be the only cause. So there must be other factors that are related to the excess weight, such as unhealthy diets and sedentary lifestyles. If obesity were the only cause, then we would be seeing a 10 to 20 year delay, but we're not seeing that because it's all happening at the same time. So there are links that are directly between obesity and colorectal cancer. So one of the things that we found is due to the increased fat reservoirs across the body and near the tumor, obesity can do a varied number of things. It can provide cancerous cells with fuel to grow. It can predispose a person to hormonal changes such as high amounts of insulin and estrogen, which can increase the rates of the cell growth. It can also lead to systemic inflammation of body tissues, releasing cytokines that further spur tumor growth. And that was new information for me. I did not realize that. So there's some other theories out there. Different theories have emerged for the causes, including gut microbiome changes and sedentary lifestyle. Some researchers blame diet-related changes in recent decades. And I found a quote, "We know that people in those younger groups are eating less fiber and are eating more processed foods than previous generations." So most colorectal cancers actually occur with people with no family history or genetic predisposition, as in the case with my very first case study, Ms. Winnegar, in addition to obesity, but these other theories are starting to emerge. So Marcus Goncalves from, I'm sorry if I mispronounced that name, Weill Cornell Medical College says the tumor can just directly eat the sugar that you are eating, and that's unique to colorectal cancer. So I've been hearing a lot. I've had some families that have passed away from cancer, and sugar is definitely a component to all cancers. But they seem to think there's a higher precedence of this with colorectal cancer. So here's a family, Tara Anderson, 40 years old, a mother of 4 from Bowie, Maryland. She had chronic constipation for years. Her gastroenterologist told her to increase her dietary fiber to ease the constipation and she would feel better. But her pain increased, so she saw another GI physician. She had a scan which diagnosed a tumor in her colon the size of a golf ball. So once again, we're seeing that trend of, you know, something's not right, and you continue to persist with the doctor. So here are some of the findings. I thought pictures always tell the story well. With increased colorectal cancer rates. So we see it with the obesity that I already discussed, sedentary lifestyles, heavy alcohol use, poor nutrition, chronic conditions such as IBS's irritable bowel syndrome and type 2 diabetes. So let's talk about the healthy diet that I mentioned earlier. So that will help with prevention and lowering risk. And so examples of that include a variety of fruits and vegetables and whole grains. If you want to see a variety of color on your plate, eat less red meat and processed meats, less saturated fat and salt. Try to eat fish 1 to 3 times a week. You want to watch your weight and not watch it go up, but watch it so you can keep it, keep it pretty standard or lose weight. Regular exercise, avoid tobacco, limit alcohol, and omega-3 fatty acids found in fatty fish, and also flaxseed oil, walnuts, and canola oil. These are always helpful. And I have some additional statistics. ACS recommends no more than 2 drinks a day for men and 1 a day for women. And then the fatty omega-3 fatty fish, examples of that are salmon, herring, and mackerel. So I want to give you a little bit more information there. Okay, some more prevention. Standard multivitamin with 100% of each vitamin and mineral needed for the standard day. Dietary fiber, that's a protective effect on the pathophysiology of colorectal cancer. Diets rich with vegetables and grains show significant protection against fatal colorectal cancer in a study of over 760,000 people. You also want to stay hydrated. You can remember, it's like, how much should I drink? How much should I drink? Well, for the average person, remember 8 by 8, and that is 8-ounce glasses a day. Of course, there are other conditions where you might want to drink more than that. You can also include a fiber supplement. So why would we do that? We want to eat natural fiber. First of all, that's more important. But if you don't ingest enough fiber, a fiber supplement can decrease the fecal transit time by increasing stool bulk. It dilutes the concentration of the other colon constituents, which minimize the contact between colon epithelium and carcinogens. Carcinogens are things that cause cancer. It's not digested or absorbed in the small bowel and undergoes fermentation in the presence of colonic flora, which reduces fecal pH and generates short-chain fatty acids. So, further recommendations for our millennials. Colonoscopy screenings need to start at age 50 for average risk. As I said when we first started, the average risk. Screening African Americans start at 45. Screenings are recommended at age 40 with a family history of colorectal cancer or adenomas in a first-degree relative. Young adults need to know their own bodies and advocate for themselves with the healthcare team. And then also, most cancers that occur before 50, they actually started growing significantly in the 40s. So some states have actually adopted that standard of 40, but others are waiting until American Preventative Services Task Force is able to adopt those guidelines and push ACS for that. So what are the next steps? We need to raise awareness in the medical community that colorectal cancer does indeed occur in younger adults, and to take the symptoms seriously. Hemorrhoids are the most common complaint in this age group. And quite honestly, when patients talk about bright red blood when they wipe on the tissue, that's the first thing that's usually present are hemorrhoids, but you definitely don't want that to go on and linger for long. But symptoms also can include constipation, blood in the stool, bowel changes, anemia, and fatigue. The bowel changes, remember with my first case study, she had ribbon-like stools, and that's a classic. We see that with colon cancer quite often. Patients may also include general digestive complaints like nausea, diarrhea, constipation, or abdominal pain. So I believe this is my last case study, and I know this young lady because she served on Hitting Cancer Below the Belt with us when we first started. This is Sarah, and she was diagnosed in her mid-20s with irritable bowel syndrome. She had absolutely no family history of colorectal cancer. She noticed mucus in her stool, and she told her doctor, and she was 39 at the time. She had a colonoscopy, unfortunately one of the smaller risks, but it is present. You can have a perforation of your bowel, and that means with putting a foreign object into your colon, you can have a little perforation, or we put a hole into the colon. Because what they did was they removed a polyp. So we snared those polyps off, and that's when she got the perforation. She had to have emergency surgery the next day. She had a positive diagnosis of rectosigmoid cancer, which I said earlier is the most common area that we do find cancers, in that distal point. She had a resection a month later. She had an ileostomy for 9 months, and that was to allow for bowel rest and healing. So she had an actual stoma on her abdomen from the ileum, which is the last portion of the small intestine. She had to undergo chemotherapy for 6 months. She had the ileostomy reversed for 1 month after they finished her chemo. So she had all of her chemo done. Usually we go back in and we scope and make sure everything looks healthy and good to go. And she saw her oncologist for 6 years. And after 6 years, he released her. And that's like, you're cured. But she does go see her surgeon annually. And in 2017, she had a totally negative colonoscopy, and she was told, come back in 3 years. So that was really great news for her. She's a really sweet young lady. So I wanted to end with Ronit Yarden's statement of patients need to be aware of the symptoms and listen to their body, and sometimes insist on getting a second opinion until getting checked thoroughly. So that part is very, very important. And then I was going to open things up. We can open up the chat for questions.
Thank you, Kristi. That was very interesting. Please, if you've got a question, feel free to put it in the chat box and I'll read those out for you. I don't think you can unmute yourself in this context. Here's one question from Amy Hawkins. Is there any link between gut health and brain health? Any research you can share related to this?
Quite funny that you asked that. I have just finished doing and preparing a presentation for our national GI nursing conference that's supposed to take place in May. That probably won't happen now, but there is a direct link between the connection between the brain and the gut. Now, so far as the definition of brain health, I'm not really up on that, but I can tell you when we are stressed, that has, which I think a lot of that is in our psyche, it's in our mental aspect, that definitely affects the gut in general, and that would include the entire digestive system. And so I did a lot of research on that, and that's why sometimes you might, your food goes right through you, for example. When you have stress, that would be an example of that.
Another question, Kristi, is, are most payers covering the cost of colonoscopies for African Americans at age 45?
Yes, they are. They are.
Great.
That has already been adopted. I'm so happy to see.
And Jackie asks, do the adenomas in a first-degree relative need to be high-risk adenomas, larger than 1 centimeter, to start screening early and more frequent screenings, or is it recommended for all adenomas in general?
All adenomas in general, because they all have abnormal tissue.
Great.
Of course, the larger is going to make you probably come back a little sooner to make sure that they removed all of it, but they automatically go on the frequent flyer plan.
Frequent flyer, that's nice, nice term.
Yeah, they come see us a little more often.
Okay, and then from Rachel, if someone has an immediate family member who had a diagnosis of colorectal cancer at a young age, should the family members seek colonoscopies before age 40?
There used to be, and I don't see the doctors doing this standard anymore, and I couldn't find research that supported it. It used to be they would take the age of diagnosis and back up 10 years, and they might still be doing that. In fact, the two young folks that were on that video that I'm seeing that y'all could not hear, and I do apologize for that because they have a great message. They are Mindy's children. Because she lost her dear husband, Rich, at a young age in his 40s. And her children have actually gotten checked very young. And they are huge advocates of colorectal cancer and are also involved on our events that we do. So I would say if you have any symptoms, I wouldn't even let that go a month. I would check those symptoms out quite early if you have a family member. If you have concerns about it, I definitely would encourage you to talk to your family doctor or your GYN doctor to get that, if you're female, to get to see if they'll do an early colonoscopy.
Now, does anybody else have another question? I just have one quick thing, just in case some people that are on the call are unfamiliar with some of the medical terms you used.
Okay.
So you used the term ileostomy,
Okay.
and stoma. Could you just quickly define those?
Happy to. Most people have probably heard about a colonoscopy, a colostomy, or a bag, when a patient has to wear a bag on their abdomen. That is when the surgeon resects their colon, and they bring the end of the colon that they have cut to the surface of the skin. And so instead of those patients having normal bowel movements and they go to the bathroom, their stool goes into the bag. It's something that we always want to prevent from occurring. But occasionally with surgery, the patients have to go through that temporarily. So I spoke of an ileostomy. A stoma is the definition of that is an opening. So the stoma is what that site is called. And you can see when you take the bag off, you can actually see where the colon is kind of coming out of the patient's abdomen. For Sarah, who had the ileostomy, it was her small intestine. So we have about 21 feet of small intestine. And the sections are called the duodenum, jejunum, and ileum. So you take ileo from the ileum and stoma for ileostomy. So that's all medicine is, big words put together. So ileostomy is the ileum that's to the surface of the skin. And that was so that her colon could rest and heal and undergo the chemotherapy and surgery. And then they hook that back up. Some people, if we find a cancer that's very low, which is the really disturbing part about colon cancer for millennials, we're finding more in the rectum, 4 times the risk for rectal cancer. That can be a really low cancer. And if it's too low, the doctor does not have enough space to connect with healthy colon. They take out that section of the diseased colon, and then they attach it back together, just like a puzzle. But if it's too low, some of those patients have lifelong a colostomy bag.
And then I want to make everyone aware, I've opened up a quick survey there, kind of a post-webinar questions. If you want to go ahead and answer those before we jump off, but also we'll stay open for more questions. If anybody has any additional questions, please put them in the chat box. I had one more question for Kristi, and it related to insurance coverage. What about for people who might be on, let's say, Medicaid or Medicare, beyond covering the screening itself? Do those types of insurance cover if you are diagnosed? Kind of the treatment and diagnosis of those things. Do they have good coverage for those things?
Well, CMS covers Medicaid and Medicare services, and that's part of the problem, is they are not, and then the patients are responsible for that additional fee. And that's what we've been trying to fight up at Capitol Hill, for them to cover it. And yes, where it is an expensive law to push CMS to pay for, we're able to tell them the initial cost that they say is, I think, $80 billion. It's 4 times that for the treatment. And that doesn't even take into consideration what the patients have to go through. If we don't encourage that, because some patients will not have their procedures done for the fear of the huge medical bill. And that's just a travesty, in my opinion. So we continue to fight. They actually have put a figure on it now. And so we're hoping that they are going to pass. But we spoke to many of the House of Representatives and also senators with their representatives, and explained to them the importance and gave stories and examples to them.
Wonderful. That's nice for advocacy. And we may have people from Virginia, but also people from across the country. I encourage everybody to find out about the coverage within your own states in terms of Medicaid. And if there are lots of organizations that really are advocating for free colonoscopy, colon cancer screenings, particularly this issue with the colonoscopy. You go in as a screening and you come out with a bill because now it's a diagnostic. And so I think we need some advocacy to get insurance coverage for those things, so that people can get screened and know that if they actually are diagnosed, they're going to be able to be treated, and their insurance is going to cover that. I think that's really important.
Absolutely. Thank you.
So thanks to everybody who is answering those post-webinar questions that I have posted. It's kind of like a poll. When we end our session, you also should be receiving something in your emails, a quick survey for you to take. Appreciate it if you take that, and if you do, you'll receive a certificate of attendance from this event. As I mentioned earlier, I'll also be providing a follow-up email to everyone after this with Kristi's slides. So you'll get a copy, a PDF of the slides that she's presented today as well. Kristi, I want to thank you personally for taking the time to do this. I know how busy you are.
Sure.
Really appreciate the information that you've provided for us.
Thank you. I hope everyone was able to glean something and learn something new today.
Wonderful. Thank you so much. And I think if there are no more questions, we'll close our webinar for today. I'll leave this poll up just for a few more minutes to see if we can get some more of you to answer the poll. And have a wonderful day to the rest of you all. Kristi, thank you again.
Thank you. Have a great day, everyone.
Okay, great. Okay, Kristi, thank you so much. I will send you, hopefully lots of people will answer our survey, and I'll send you the results to that as well.
Okay, that sounds good.
Really appreciate it. Have a wonderful day.
Thank you. Did I do okay?
You did great. You did great. Great information.
Okay, wonderful. Wonderful. I hope it was helpful. Well, have a great day too. It's really nice getting to meet you.
Nice to meet you too, Kristi. Hope we see each other again.
Yes, ma'am. Bye-bye.
Bye-bye.